welcome to all our viewers. I'm Dr. Shatil from the Clinical Engagement team at DocPlexus. Welcome to a brand new session of the DocPlexus panel discussion. In India, there is a growing realization that healthcare outcomes can be achieved optimally only if increased access to healthcare service is matched with improved quality of care. If we talk about the public sector, the National Health Policy 2017 has for the first time recognized the need to ensure adherence to standard treatment guidelines in both the public and private sector. If we are looking at the vast private sector, which is largely unregulated, is known to use non-evidence-based unnecessary interventions, including expensive diagnostic tests and surgeries to maximize their profits. There is a need for introducing clear national standards for care, as well as implementing these standards strongly with regulatory oversights. To discuss this, we have with us 5 eminent speakers today. Dr. Ashok Gupta is one of them. Dr. Ashok Gupta is a renowned reconstructive plastic surgeon with over 35 years of experience in his field. He has also received several international awards, including Sheikh Hamdan bin Rashid Al Maktoum International Award and Queen Victoria Commemoration Award. We welcome you to DocPlexus.
Thank you.
The next speaker which we have with us is Dr. Reena Nayyar, who is the Executive Director of Faculty of Health and Medical Services, SGT University, Haryana. She is also working as the Additional Secretary of the Medical Council of India. She has contributed a lot to healthcare by being the part of member of committee formed by Ministry of Health and Family Welfare for introducing a phase 2 under centrally sponsored scheme of establishment of new medical colleges attached with district referral hospitals. She has also been a part of member of committee formed by the MOHFW regarding proposal for amendment in regulations to prescribe upper age limit, number of attempts and reservation for persons with disability candidates for NEET. We welcome you, Dr. Reena.
Thank you, Shri.
Next, we have Dr. K.K. Kalra, Chief Executive Officer of NABH, a constituent board of Quality Council of India, set up to establish and operate accreditation and allied programs for healthcare organization. He was a member of the accreditation committee of NABH for 2 years and also a member of governing body, Chacha Nehru Bal Chikitsalaya Society, Government of NCT of Delhi. 28 years of experience in healthcare service, out of which he has 12 years of hospital administrative experience. He has a significant contribution towards polio eradication program, which while working as a surveillance medical officer in WHO from the year 2000 to 2002. We welcome you, sir, to the DocPlexus platform.
Thank you.
Next, we have with us Dr. Avinash Supe, who is the Director, Clinical Governance and Head at the Hinduja Hospital, Mumbai. Dr. Supe comes with more than 36 years of experience in various capacities from lecturer to director in SAIT GS Medical College and KEM Hospital. He is the recipient of the prestigious Dr. B.C. Roy Award, along with many other national and international awards. We welcome you, sir, to the DocPlexus platform. Next, we have with us Dr. Arun Jamkar, who is currently the Distinguished Professor at SIU Pune. He is the Healthcare Consultant at the Persistent System Limited. He is the ex-Vice Chancellor of the Maharashtra University of Health Science, Nashik. We all agree with the statement that he makes, and I quote, "Medical education should aim for creating better doctors to improve healthcare and elevate the quality of life of common man." We welcome you to DocPlexus, sir. So, Dr. Ashok Gupta, we are all happy to have you.
Thank you.
Thank you, sir. We are all happy to have you here. It's a pleasure to host you here today. You may now begin with the panel discussion.
Yeah, thank you very much, Shatil, and thank you everyone, Dr. Reena Nayyar, Dr. Kalra, Dr. Supe, for accepting I made the proposal. And I just want to give 2 points for introduction. standard of care, that's the topic of today's panel discussion, and what is the role of regulatory bodies in maintaining and enhancing the standard of care. And I strongly believe that they can be a minimum. There is no limit to maximum. There's always a possibility of excelling the minimum standard, and we should try to achieve that excellence rather than sticking to the minimum or even requesting people. When I was there was like 40%, 50% is minimum passing. I remember when Professor Jamkar was at the VC at the MUHS, there was a proposal to reduce this to 35% for passing. And they say, then what is the need of holding exam if that is the discussion? So I think there has to be some standard of care, both in terms of healthcare and medical education, and there can't be a better panel than what we have. I just want to raise 4 or 5 points before we say we must define what is the legal definition of standard of care. Then what is the liability of in terms of healthcare institution of maintaining a standard of care, so that the law enforcing agency can be guided what should be followed. And as a doctor, court often frequently upheld the standard of care is what is minimally competent physician in the same field would do in the same situation. But then our training is not really uniform, there can be better person than Dr. Supe, Dr. Jamkar and Reena to tell us what is the minimum standard we should teach our undergraduate and postgraduate students. So what is the duty of a physician? How we can define a negligence? What is the definition of no harm to be done? What are the and how we can maintain, who determines the medical standard of care, and how we set up the standard of care for specialists. And with these few introductory remarks, I would invite Professor Dr. Kalra to give us the full detail of what is the standard of care as a ex-director of NABH, which is one of the strongest regulatory body. Thank you. Welcome, Dr. Kalra.
Thank you, Dr. Ashok Gupta ji, for inviting me in this platform. I will start sharing my screen. I think it's visible to all.
Yes, sure.
Yes, sir.
Standard of care. An objective is to provide the working physician with a practical and useful model of standard of care to help guide daily practice. This has a special relevance to emergency department physicians for patient safety. Why this is important standard of care? Because we know the quality care which matters. If the care provided is not of a quality, then definitely there's a possibility of liability on the service provider and institutions, and satisfactory experience of the public or the patients and the attendants, which is most important, that is affected. So far in the world, there is no legal definition, no definition in the legal system of standard of care, except few guidelines and advisories issued from various courts around the globe, and in India from Supreme Court and High Courts of their states from time to time. When we talk about standard of care, definitely when we talk about quality care and litigations, liabilities, the question comes about negligence. We cannot define standard of care without understanding negligence. Every emergency physician should be aware of these landmark cases that define the standard of care. In addition, physicians should be familiar with the content of various clinical practice guidelines so that one may practice by them or document reasons for deviating from those guidelines. Negligence in general is legally defined as standard of conduct to which one must conform, and is that of a reasonable man under likes or similar circumstances will provide. In law, the medical malpractice is considered a specific area within general domain of negligence. It requires 4 conditions or elements to be met for the plaintiff to recover damages. These conditions are duty, the breach of duty, the harm, and the causation. The second element, the breach of duty, which is synonymous with the standard of care. Emergency physicians are on the forefront of medicines and are frequently involved in medical malpractice cases. It's estimated that 7 to 17 malpractice claims are filed per 100 physicians every year. This is as per US data. Courts have frequently upheld that the standard of care is what a minimally competent physician in the same field will do in the same situation with the same resources. The clinical practice guidelines are being used more frequently in the court's cases as support for the standard of care. However, their acceptance and uses are continually changing and decided on the case-to-case basis. The historical development of standard of care with time, initially about 2 decades back, initial definition which people understood regarding the standard of care was based on the customs. That which are typically done is what is considered a standard. A group of people of a same specialty, how they manage their patients, that was considered as a customary and that was acceptable initially. Then in the 20th century, definition changed because of the litigations, the various cases. These changes were due to the litigations and court advice, and now to this custom that which is customary done, plus anything that seems reasonable word was added, even if not typically done. And modern definition is that with a minimally competent physician in the same field would do under similar circumstances. We cannot compare the standard of care of a metro city having tertiary services with that of a district hospital or even a sub-district hospital in rural areas. They may differ. So who defines this reasonable care? Is the legal system defines, or it is a group of medical professionals have to define? Standard of care does not mean perfection in practice. A jury still needed to decide, however, whether this custom was reasonable and whether the deviation from this custom was so unreasonable as to cause the harm. What is commonly done as a custom may not be enough, and that there are some things that may not be standard but still reasonable for a physician to perform. Example is of a young patient coming to an eye surgeon for some problem, and glaucoma was not considered. The intraocular pressure was not taken in the young, and the patient suffered from vision loss. It was customary at that time that in young patients coming to an eye doctor, the intraocular pressure was not necessary to be checked in every patient. But then when people became aware, even glaucoma was found in young people, then it was made customary. It was added, although not customary, but in some cases, definitely intraocular pressure to be monitored in every patient, young or elderly. Standard of care is not met when the defendant or defendants fail to exercise the degree of skill, care, and learning process possessed by other person in the same profession. Medical malpractice is a legal fault by a physician or a surgeon. It arises from the failure of a physician to provide the quality of care required by law. When a physician undertakes to treat a patient, he takes on an obligation enforceable at law to use minimally sound medical judgment and render minimally competent care in the course of services he provides. A physician does not guarantee any recovery. A competent physician is not liable per se for a mere error of judgment, mistaken diagnosis, or occurrence of an undesirable result or outcome. From a physician's standpoint, is that the law only requires minimal competence. The care does not even has to be of average, which makes sense. Otherwise, 50% of all medical care would be malpractice by definition. Medicine is an inexact science, and generally qualified physicians may differ as to what constitutes a preferable course of treatment. Such differences due to preference do not amount to malpractice. The clinical practice guidelines and standard of care. Several courts have addressed the use of CPGs, and currently there is no set standard for how these documents are used in the court cases. Some courts allow more liberal use of the CPG, and others require more scrutiny as to the scientific validity of the CPG before it is admitted. Normally, a document like a CPG would be considered hearsay in the court, as the author is not available to testify or to allow for cross-examination. However, the court cases dealing with the CPG use have suggested that if the guidelines are of some scientific validity, that they may be used as a learned treatises and bypass the hearsay rule. CPGs may be used to lend credence to an expert witness, to impeach an expert witness, to defend a physician for the following the document as the standard of care, or to suggest physician deviance from the document as deviance from the standard of care. In the end, the explanation by an expert as to why a CPG is indicative or not indicative of standard of care goes a long way in the court cases, and still discussions are going on. Why this may or may not actually represent the standard of care, the CPG. This is continually evolving topic and is currently dealt with on case-to-case basis. Now recognizing the complicated issues that arise with formulation of CPGs, it would seem optimal that committees who develop these guidelines should allow flexibility, include multiple sources of scientific merits, and not be dependent on the opinion of a relatively small panel. In addition, if clear evidence is sparse, this should be openly acknowledged in the formation of the guidelines. Criminal liability can be fastened pursuant to the provision of the Indian Penal Code. Nowadays, there's no particular act. All these negligent cases are being dealt under the IPCs, the various sections of IPCs, which was developed in 1860. Like 304A or 3374, 3385, and other various IPC clauses are being used for deciding the case. Basic features of medical negligence and standard of care. To comprehend the scope of negligence, it is important to understand the scope of duty of imposed on a doctor or a medical practitioner. A doctor or other medical practitioners, among others, has a duty of care in deciding whether to undertake the case or not. Duty in deciding what treatment to give, duty of care in administration of the treatment, duty not to undertake any procedure beyond his or her control. And it is expected that the practitioner will bring a reasonable degree of skill and knowledge and will exercise a reasonable degree of care while providing service to a patient. a line between civil liability and criminal liability is very thin, and no sufficiently good criteria have been devised by the Supreme Court providing any clear and lucid guidance. The various cases, Supreme Courts and High Courts have given various advisories, and Boland test is to be applied. The standard of ordinary skilled man exercising and professing to have that special skill, not of the highest expert skill. This is applicable to both the diagnosis and treatment. It is noted that the Supreme Court has now observed the need to consider the parameters set down in Boland test. As per US Legal Information Institute, the standard of care is an essential concept in determining whether a person was negligent and potentially liable for a tort. If a person breaches the standard that applies to them and their action cause harm to another person, they will be liable for negligence. In legal terms, the standard of care is used as a benchmark against a healthcare provider's actual work. The healthcare provider only has to meet the test that he provided the care that a minimally competent healthcare provider would have done in the same situation and given the same resources. To sum it up, the following three conditions must be satisfied in order to establish the tort of negligence. There must exist a duty of care which is owed by the defendant to the complainant. The standard of duty of care must be violated by the defendant, and a legally recognizable damage should be suffered by the plaintiff as a result of concerned breach of duty. So standard of care is the degree of the care, skill, and diligence which is reasonable and prudent man is required to use in a particular situation in order to avoid the imputation of negligence. The duty of care required in each particular case will depend upon the magnitude of the risk involved, the importance of the object to be attained, and the practicability of precautions. The standard of care required is a matter of law and does not vary according to the individual, although it does vary according to the circumstances. So how to ensure standard of care is exercised by all in all circumstances? This is possible only by improving the system and processes by way of healthcare quality standards. The various accreditation standards in our country, all over the world, most of the time the countries, they have a accreditation standard which are voluntary. Very few countries now have started coming out with a mandatory accreditation standards. In India, NABH, which is the autonomous body under Ministry of Commerce, the NABH accreditation standards for various types of institutions are there, but they are voluntary. JCI, Australian, Canadian, and so many other accreditation standards are being now used in various hospitals. The government standards, NQAS, the IPHS standards, they were there they were revised in I think 2012. Then Clinical Establishment Act came. Under this act, the various types of some standards were laid down for various types of the health institutions in the public as facilities. And so far, the Clinical Establishment Act uniformly has not been adopted by all the states, although many states have adopted, but implementation is still questionable. And moreover, these IPHS and clinical establishment standards, they're based on basically on credentials and few numbers. They do not require much of a processes improvement. even those are not being fulfilled by most of the public hospital institutions. Then Medical Council of India, then came the National Council, and they regulate the education for medical educations, and all these NABH and JCI standards. They are basically for the hospitals, for the patient care, how they provide, how care should be provided. Then there are few regulatory requirements like fire safety or some explosives, some license for those things like oxygen tank and oxygen reserve for therapy. You require, if you are having some oxygen plant at the hospital, and definitely you need to require, especially the liquid oxygen and other plants, you require a clearance certificate from particular group of government authorities. Now, under the Ayushman Bharat scheme, the Prime Minister's, which is a main healthcare yojana, certain guidelines, standard treatment guidelines have been adopted for basically for quality of care, and there should be accreditation system of all the healthcare institutions and professionals. When we talk about the NABH standards or GCI standards, so far in our country, full accreditation of only roughly around 800 hospitals is there. And then we know there are more than 60,000 hospitals in our country. So this Ayushman Bharat, that's SDGs, which is the booklet also that is available on the website. And this also talks about the minimum standard of care is needed. So when they are writing the SDGs guidelines for every procedure, they also require a minimum standard of care. So far, under these Ayushman Bharat guideline SDGs, there are total 625 guidelines covering almost 1,572 various procedures. But most of these guidelines, again, are used for pre-authorization clearances and for claim processing. They are also basically not like NABH or JCI standards. They are confined basically to very few parameters, some qualifications of a doctor who can do one particular, who can treat a particular type of a patient, and few numbers and few indications. Much details I found still more to be needed for further revision of these guidelines. Thank you. This is all I have to say about standard of care. Back to now, Dr. Ashok Gupta.
Thank you, Dr. Kalra. Wonderful presentation. And I mean, of course, you have elaborated so well the requirement of a standard of care. I have only 2 or 3 points of what you have presented. I mean, I will share some of the points during my tenure as a member of Board of Governors at the MCI. And you mentioned there is a very thin line between criminal and civil liability in this thing. And most of the medical malpractice insurance does not cover the criminal liability. Yes. So there's a big challenge for all the doctors. So there has to be some criteria where we can define what is not criminal and what is criminal. Second point, which of course you mentioned that review by a small group is not something tenable, but it used to be practice. I don't know, maybe practice even now also, that whenever there is a medical legal issue or there's a ethical issue, we used to refer to a peer group of experts. And if those peer group of experts are working at a high tertiary care hospital, their view and vision will be of that level, not a person at the primary center. And third was, during our tenure, we also used to say that MCI team or the NAB, the commission team, when they go for inspection, they look at the size of the hall, they look at the number of beds, etc. But quality of wall, the quality of hygiene, etc., are not covered. And we are saying NABH should be mandatory for all medical colleges. They should, if not approved, at least they should stick to the criteria, minimum standards proposed by NABH or any regulatory authority. And I'm sure Dr. Reena Nayyar and Dr. Supe have a lot of things to add into this point. Yes, Dr. Reena.
Sir, I totally agree with what you have said, that apart from just measuring rooms and seeing the infrastructure, we should go into the processes, and because it's basically, if the processes are adhered to, then obviously the standard of care is also up to the mark. But that said, when the minimum standard requirements that have been prescribed by Medical Council of India and now the National Medical Commission, they look into everything. It's not just the infrastructure, it is the faculty, the staff, the support services, the safety and security, the management system, everything. So all that basically is required for proper education of the doctors that we are producing, who in turn are going into the healthcare system to finally practice. And so that it all is interlinked. That's what I feel, that if you give good medical education, it would ultimately turn into a good medical practice when the doctor is out into treating the general public in the healthcare system, Indian healthcare system. So, and there is a difference between the regulatory body and the accrediting body, because the regulatory bodies, they have a statutory authority, whereas on the other hand, the accrediting bodies, they do not have that. So they do not have a legislative jurisdiction in these kind of cases when you have ethical issues or medical negligence or all those cases. Then ultimately it is the council's ethics committee or the National Medical Commission's ethics committee that is going to look into those matters. So that is the difference between these two. So ultimate legal jurisdiction lies just with the ethics committee of the regulatory bodies. Rest of them, whether it is the Indian Public Health System Guidelines or the Clinical Establishment Acts or even the NABH or JCI, those are accrediting bodies who have laid down processes which should be adhered to, because they also ultimately improve the patient care and the quality of the care that is being provided. But they do not have those the legal jurisdiction which the regulatory bodies have.
Yeah, that was the point which I was trying to say, that even if we go by the minimum standard, if these accrediting body can set a guideline, these are the minimum standard, which can be adopted by the regulatory body unless you fit into these minimum standards. I mean, I remember we said we were talking about the hall size, but we are not talking about the plaster in the wall. We are not talking about the infection in the wall, the electrical fitting and all those things, which also are important measurement for this thing. And of course, everybody says we must have the good education. And like we were discussing, from where we get the teachers, and are the teachers being equally updated? And we have Dr. Supe, who has been a very prominent figure in the teachers training program.
Sure.
And I'm sure.
Sure. Thank you, sir. Thank you. I think really, Dr. Kalra, you spoke up to the point, and he referred mainly two major issues. One was he referred to the standard of care, and I think he referred to a landmark article which had come by Moffett and Murray in Western Journal of Army Medicine, and I think that really defines these three definitions of modern definition of standard of care. And I think he went through all that very nicely, and he gave the complete idea what is the legal situation in the Western world, and also he talked about the Indian world. Now, to be very frank, in our country, there is no definition of standard of care. So we depend on what, as you said, what minimal competent person. Now, ultimately, when it turns down to be converting into practice, there are, as you said, Dr. Gupta, either we take help of 2 or 3 consultants, or we take the help of the clinical practice guidelines. Now, again, if you go a little deeper into this, there are 2 aspects to this. One, whether there is a clinical judgment where people have not made a judgment which is proper, or the diagnostic treatment is not given properly. That time, if you really see, there is a very little scope if the judgment is little wrong. Somebody can go wrong. But the breach, if it has caused harm, and which is somebody would have easily diagnosed, which is very careful. Now, such incidences are very less. But the other aspects which NABH looks into, something like the impact of the process, like fall, if there's a fall incident, or there is something which is very grossly negligent. Now, these are picked up very well and they can be legally sued. But the judgment, whether he really missed the diagnosis or whether he really made an bad operation, I think this is still not under the legal, unless, and it's very difficult to prove into the practice. So that is a major problem. The second point is of clinical practice guidelines. Now, most of the clinical guidelines, I have been involved in developing many international clinical guidelines. And as you rightly said, when there are about 50 members across the world, you have to be more flexible. You can't just have rigid guidelines. In fact, when you are creating MCI regulations, you have to really consider whether an Manipal or Assam people will be able to do it. To give you a simple example, once I was making one guidelines and I was trying to say that all the deliveries must be done by a trained diploma or degree holder of gynecology or obstetrics. There was a sudden objection and saying that no, even an MBBS graduate has to do it, because what they will do in a rural area of a Manipal. So sometimes you have to consider our country and you have to see in those situations what they will really do. So standard of care, as you rightly said, varies from place to place. And there is no legal definition to this. And which I think very rightly said by that article and the overall Supreme Court judgments which have really come. The third point I want to mention, which I think you briefly said, was, I was working on this topic for last 5 or 6 years, was credentialing and privileging. And these are the two words which are commonly used in the Western world today over last 10, and especially it came after that robotic case. I don't know whether you heard about that Cooper versus the Intuitive surgical case. It's a very famous case. In 2015, the judgment came. There was one doctor who had done many prostate surgeries and he operated, and there was a rectal tear and the patient had afterwards recovered, but then he died early. And the Supreme Court said that the hospital is also involved, the company is also involved, and the doctor is also involved in this because they did not take proper care. And since then in USA, credentialing and privileging started becoming more and more common. So what is credentialing? Credentialing is like what we test, whether he has adequate qualifications and experience and all. But privileging is very important, and very few hospitals in India do it. They would like, when they appoint a doctor or they will review a doctor's practice, they would like to look at it, whether that doctor is capable of doing these operations like frequently, and is he capable with what are his results. Something like that. Tomorrow, I cannot go on doing a surgery which I have not done for 20 years or 30 years and which is a complex surgery. Better I be out of that. To give another example, simple example. There are many anesthetists today who go into an ICU and they go as an intensivist for 20 years. Now, I cannot ask that anesthetist just because she has an MD anesthesia, she can go and give a complex case into an OT. So the credentialing and privileging has to be done by the hospital. So if you really look at the whole topic of standard of care and the regularity bodies, standard of care, somebody has to define it. Either the hospital has to say whom you are going to privilege. Regularity bodies only can create an environment and some kind of guidelines. Clinical guidelines have to be more flexible, like associations can make it, like the Indian Association of Pediatric or Indian Association of Surgical Gastroenterology, but they will have to be very flexible. And ultimately, these cases and the legal matter are caught on a very contextual basis. I think that is where it really comes to. There is a lot of unclarity in this topic. So when you ask a question, what is the role of a regulatory body? I think, say, bodies like NMC or MCI can only make everyone aware of this. They can bring this topic, they can update their teachers and the graduates which are really coming through. And as Dr. Reena Nayyar rightly said, through their ethical committees and their regulatory committees, when these cases come for their discussion, they should follow the same principle what Dr. Kalra said, and they should really try to see, and rather than having biased judgments or something like that, they should try to follow the same principles which are quoted in this article. So I think this is where we need to look at this broader spectrum rather than trying to just say that regular bodies have to do. But regular bodies does not have that much material or any kind of thing to really take a decision. That's a problem with them.
I think what I have realized also during my tenure, the Medical Council of India was very short of hand. They did not have manpower. They did not have access to so many resources to regulate such a huge thing. So unless we have a standard guideline by various specialty boards and specialties, that will go in a long way. Professor Jamkar is also there. Dr. Jamkar.
Before Dr. Jamkar speaks, I want to say only one point.
Yes.
These whole guidelines are very dynamic, sir.
Yes.
Yeah.
As you know, the knowledge is changing every 72 days.
Yeah.
The guidelines have to be changed every 2 or 3 years, sir. They cannot remain static. I read in 2010. They are no way important today.
Yes,
the guidelines are dynamic.
Yes, correct. Absolutely true.
And sir, what you mentioned about credentialing and privileging, that is being done, I think, in all the hospitals that are now going for NABH or maybe JCI.
Corporate hospitals.
Corporate hospitals. But even the smaller hospitals that are going for these accreditation. But it is still a problem with the public healthcare system.
Sure.
I think the Medical Council or NMC should try to include the minimum standard in medical colleges. I mean, there comes the role of a university, health universities, where they can also guide. Professor Jamkar.
Yeah. Thank you, Dr. Gupta. I think, am I clear? Am I audible?
Yes.
Yeah.
Yes, very well.
Actually, it shows two things. I'm on a resort called Talish, which is in the Nane Ghat, and internet being available. So I think our internet penetration is increasing. So I'm just on the verge of a down. The Kokkan is there. So anyway, this is my very fascinating topic, and everybody agrees that you require a standard of care, and then we require regulation. But then who will do that? The most important question is who will do that? And standard of care, once it is established, it will help everybody. It will help patients. It will reduce violence. It will reduce what you call as negligence and everything. But then we are not very sure about how to get it done. So first thing, as Dr. Supe has already said, the standard of care could be in two parts. One, all these guidelines which need to be dynamic and which should be maybe validated by an association and with a peer group. And I think every association should have some sort of a website, something like LinkedIn, where every practicing doctor under the association should put his credentials, which should be validated by the peer group and colleagues. So that will send a message that somebody is doing robotic surgery, and then others should validate that he can do it. Otherwise, everybody is starting doing laparoscopic surgery without knowing, say, what are the complications and maximum complications and maximum say, litigations were in laparoscopic surgery, especially in gallbladder. So I think this is the first part of story, that the validation, credentiality has to be done before we make it public. But then if we keep that whole thing to a regulating authority, then we are in soup. Because then everybody goes in to find out what are the ways of deceiving it and maybe.
I think we are lost.
Yeah, there's some problem with
internet. I think the problem with regulatory bodies is like
should upload their clinical data for a clinical audit, which is available to public, so that public can choose who is better doctor. And then obviously the chances of negligence, everything would be there. So regulating authorities like National Medical Commission definitely have a role to play. But then after NMC has come into picture, all those inspections, they are not calling it inspections and they're not calling something else. But then the pattern hasn't changed. Nobody sees that our medical college is really teaching. They just go on, say, finding out what is the ecosystem, what is the. Obviously, that whole attitude has definitely changed. But then I don't think nobody, now I have attended 2 of those NMC inspections, but no inspector was asking, do you teach? And that is something which I think has to be modified. And we should modify something like a NAC, where everything is available for upload, and then it is self-regulation, so that people will, all these hospitals will try to do something better. Now NMC never sees what is accreditation. So Dr. Supe might remember, we wanted NMC to implement NABH for all hospitals under medical colleges, but I think so far they have not done. So at least if you have NABH hospital, say standards, the standards for the laboratory, standards for the clinical services that are given, so that at least the standard of care in medical colleges would go up. And if the students, medical students, know what they are watching, then it can help to maybe implement themselves when they are actually practicing. So my conclusion is, of course, we require standard of care. It has to be self-regulated. It should be validated dynamically, and at the same time, it has to come from with a peer group, associations, and something like a LinkedIn profile available for every physician. So, and it should be public, so that the patients going can watch what you want to do, and then choose a surgeon and choose a physician. Thank you.
Thank you, Professor Jamkar.
Dr.
Yeah, Dr.
Gupta,
Kalra. Yeah, Dr. Kalra. Yes.
So,
Yeah, Professor Kalra. Yes.
as a regulatory body, when we're talking about, I remember during my tenure as a NABH, in the NABH, we tried and brought out an order from IRDA, which is an insurance regulatory body. All those hospitals undergoing under their scheme some insurance processes, they must undergo within a year time the minimum, not full accreditation or other small accreditation program, entry level accreditation of NABH. Every hospital, to ensure that minimum quality care is there in that particular impaneled hospital for insurance services. I remember after a year time, this timeline was extended for another 1 year. Then I came to know about a year back. So far now that insurance ability IRDA has removed that mandatory clause.
Mandatory clause.
So we are
True, sir.
talking
Very
here
true.
the role of regulatory bodies, and whatever, even we made an attempt and few hospitals came forward, but IRD also has to remove that clause, mandatory clause. I don't know why, but for.
No,
I just
sir,
wanted
I
to add,
personally-
Dr.
personally-
Kalra. Hello.
Yes, please.
Yeah.
Yes.
Actually, the model that NAC uses is, I think, reasonably perfect, where everything is on uploading data and maybe 10 indices.
Before you may I come in, sir. First of all, the NAC standards, they are basically a standard for the education part.
Yeah.
The professional
NABH is a
skill
practice,
development, and NABH is basically care processes. They are both are different.
So what
They
I
are
wanted to say,
complementary to each
that
other.
we need to struggle for
Yeah.
us to get in NAC. Earlier,
Yeah.
health profession universities and colleges were not under NAC.
Yes.
So, as a chairman of Vice Chancellors Association of India, we influence them to include health professional education.
Yes.
Otherwise, earlier everything was non-health professional. So I think that is one step ahead.
Yeah.
But the same thing, maybe like NABH, we should have some standards of healthcare under medical colleges, or then we can have something like tertiary hospitals, maybe secondary hospitals, and then primary care hospitals, because this gradation has to be there. And this has to be correlated with the cost of service. I think people try to just forget that if you have a very good hospital giving you highest standard of care, it has to be costly. And then suddenly public says, why it is so costly? So I think this part also has to be kept in mind.
No, Dr. Jamkar, See, I think we have to understand in India, trying to put on next day, today there is no, and second day we are trying to put mandatory, Dr. Kalra, it doesn't work in our country. I always see the best way what income tax department has done. I think that's the best way to tighten the strings. They initially made in 1996, only a PAN card was introduced, maybe at that time. And then they slowly went on tightening these purses over last 20 years. And now see, you cannot do a transaction without PAN card. You cannot do everything without something. And now I think people have limited ways of really spending a black money. And I think that is the way they have really tightened that strings. So I think in our country also, when we are now trying to put NAC or NABH, I think you said out of 60,000, only 800 have taken it, maybe 1,000, which is very less. Now, I'm sure you are making it voluntary. Over a period of time, you start introducing some features as a regulatory body, which would help them or which will make them go towards NABH.
That is already a part of the NMC Act, actually. So the NMC has the mandate of, they can appoint and outsource it to a third agency, and MARB is basically medical assessment and rating board. So for rating, they can, employ associate with NABH, get those standards, or maybe they can, introduce even NAC and make it mandatory for the medical colleges slowly to go for those. Many of the medical colleges are actually going for NABH. And even NAC. There are quite a few who have already got their NABH.
Now there are so many medical college hospitals are.
Yes. So it is an NMC mandate. They just have to implement
See,
it.
One of the simple way regulatory bodies do it, if you are NABH or NAC accredited, to make it some benefits or some kind of, if you start beginning in that way, automatically people will start going and doing all
kind
that.
Of relaxation if they have an NABH or.
And see, the most important part is, as it was brought out, all these NABH and NAC, why they are different from routine inspections, because they are trying to study some degree of impact. And we are interested in
outcome based.
Yes. Outcome based. We are not interested only on to the what exists. I think we need to have impact based, and that will automatically improve the standard of care.
But one thing is that going for NABH and NAC, these are expensive processes. So not all hospitals, on different levels, like so I said, Dr. Jamkar, that we have to go level wise. So, we cannot expect the smaller setups to immediately go for NAC or NABH because they are expensive processes.
See, there is another thought also. There are many people who would say, and Western world, many of them say that too much of accreditation doesn't improve the service. Many doctors continue to only go on writing and writing and writing.
So I think
documentation. So there is a different way of looking at it. We need to also see that we concentrate more on the impact and the outcome rather than too much of processes and documentation, where you could make it automation can be really brought into this. And I think we need to see how the service is improved rather than the cost and all that kind of thing. So these are a lot of issues. These are not discussed. Nobody's really, taking this to the regulatory bodies. I think these are areas, I think, Dr. Gupta, you rightly said, we need to really work on as a country.
Yes,
I think, Dr. Gupta, one thing I want to add, which can be done immediately, is while NMC is doing inspection, they should insist at least upon clinical audits of all the departments for at least 1 year. So what is your patient role? What exactly has been done? What is morbidity? What is mortality? And what is the outcome? So at least somebody will ask us, then it will start reflecting and sensitizing medical colleges that how is the care. Then it will percolate down to their students.
Sure. Dr. Jamkar, I must tell you this experience. About 20 years ago, 2000, World Bank gave some loan to Maharashtra government. And they insisted that we should have clinical audits, of the whole system. So I was appointed as one of the experts in 2000 along with Tata Institute, and we developed the whole spectrum of clinical audits, and we really developed parameters and everything. We went and trained all those district officers and everything. But I think the take on those people was so frustrating that nobody would really, we had only created 12 parameters to begin with, and performance indicators and all. But those were also not accepted by the government sector. And the results were, we are talking about everybody putting how many operations I did, how many failed, and all that kind of thing. Our society is not mature enough to really accept these kind of figures. I think we need to improve that standard of care culture into our institutions. I think this is where now when the number of doctors will increase and there will be better competition, that's the time we have to introduce this standard of care culture so that we will be able to bring little amount of audit and accountability. I think this is the time to act by the regulatory bodies to bring in this slowly over next 5 steps.
This needs to
So
be
at present, Dr. Supe, I am with Symbiosis, and we want to develop this culture of.
We are not able to hear Dr. Jamkar.
It's got stuck. Lost connectivity.
Yeah.
This actually needs to be
And,
included in the curriculum, So at the MBBS level itself.
No, but
I think that's what Dr. Jamkar wanted to say.
My concern, Dr. Reena, was that whatever we do, ultimately it is the resources at the individual medical colleges, at the regulatory body, how with the increasing number of medical colleges being opened in several centers, we don't have enough faculty, we don't have enough infrastructure. How much minimum we are going to care for the standard of care? There has to be at least some level below which is not acceptable.
Very right, sir.
And Reena, I must tell you, I was Dean Director. I tried to introduce so much of NAC and NABH and our hospitals. We had so many meetings and we tried to prepare documents. But over a period of time, what happens in public sector, if something else comes and the whole momentum gets lost. And I think there is somebody is not pushing you and everybody feels we are making them overwork and all that kind of thing. So unless a mandate comes and some kind of thing comes, these things will not happen at a public sector.
It has to be made mandatory, sir.
Mandatory, but slowly we have to bring it. Something like there are say 10 criteria or something like that. Ask them, okay, at least 2 criteria should be made in the beginning, 3 criteria. Then slowly you would go on tightening it.
Yeah, like NABH has a pre-entry accreditation level. And then
something like that.
Yes, yes.
Something like that we have to do it. And then we'll have to really bring that, we have to really think thoughtfully how we can really bring this into the public sector. Because public sector is I've seen all big institutions, but they're very poor take on that. Dr. Kalra would tell me why it is not.
Dr. Reena, I think because you are in NMC, maybe to begin with.
I'm not, sir.
Not now.
And then no. So maybe we could just send a resolution that at least make an voluntary NABH to all medical college hospitals. So it will at least start.
Yeah, that's the question I was to ask Dr. Kalra also. What I understand, NABH sets the criteria for the hospitals, but are there separate criteria or little diluted criteria which could be applicable for medical colleges while doing the training and teaching? Because most of the medical colleges are probably failing into the criteria of NABH or JCI, whatever we are doing. You have to unmute Dr. Kalra.
This we are trying for since long to introduce quality concepts, quality and safety into the undergraduate curriculum. I think now this year they have started.
Even see the new curriculum, which I know we have done this competency based and all. We have included this.
Yes.
We have included, but I still have concerns how it will be really taught at a ground level. See, putting in a curriculum is okay, but we need to create a module and make some kind of a faculty training so that it reaches to everybody and then it goes down to the ground level.
Sir, I give
Dr.
you
Dr. Supe, why don't you create
one thing, sir. We're talking about standard of care. Now,
Yes,
I'll give you one example. I remember when I was in NABH, I will not name the state. One of the states of India, 100-bedded hospital, they were only having 7 qualified staff nurses working in the hospital, 100 beds. What kind of standards of quality care we expect under such circumstances? The secretary of that state, they understood where he said, we are making an effort to include more, to recruit more nurses. But even IPHS standard also is given a minimum number of staff nurses for a particular type of facility in the government hospital. But this is not being adopted by a secretaries, and I will say it is a political will. In our country, the most important, if we want to improve the standard of care in our country, first we need to in favor of the politicians, then the administrators, state administrators. Only then things can improve. This was not exactly, go to the example of one hospital. There were so many hospitals, quite understaffed. How we can expect the quality care in such circumstances?
Dr. Kalra, one of the stumbling block in maintaining all these standards, especially in medical colleges, is budget. And because all these medical colleges...
Budget, I will not agree.
Listen me.
Budget is not the true reason.
Listen to me.
I have been in a government hospital for my full life. Although I was in Delhi government or even center also, actually, this is not an acute shortage of the budget. It is your attitude and the commitment. How you use to budget allotment.
Not necessarily, sir, because with so many medical colleges and associated teaching hospitals coming up, not all the public sector is different, but the private sector, many of them don't even have that kind of patient load. So then they don't want to employ as many nurses or maybe the support staff. They try to cut down on those because they don't have those kind of patients.
No, my point to raise, at the end, 500 and around 30, say 70 medical colleges across the country, they are creating a set of tertiary care across the country, which is not able to be achieved by government. And government doesn't spend anything for them. So at least for the tertiary care that these medical colleges are creating, there has to be some partial funding by government so that they'll be able to exercise their regulations. Now everything is left to them, and now latest circular Parliament has already passed that 50% seats has to be with the government fee, and now we have to think of how all these colleges will be financially viable.
Yeah.
And so at the end, government has to give some funding for maintaining at least say tertiary, whatever you can say maybe 25 rupees per day per bed. Something like that, but there has to be some partial funding from government.
So that is the reason, Dr. Kalra, the number of nurses and number of the support staff goes on decreasing.
Actually, I have the privilege of working in large government-run medical college, a large private sector hospital, and there's a vast difference between the private run trust-run hospital and a public sector hospital. And I think that itself is a big challenge to, it may be different in Delhi government, may be different in central government, but I can say vouch for, and I used to say the entire government of Maharashtra budget is much less than what the AIMS get for one AIMS. So one AIMS get much more money than the entire state of Maharashtra run medical colleges. So budget is a big constraint in all our colleges, medical colleges. I'm sure this must be issue with the other state also. So unless...
Dr. Kalra, to give you example, 22 budget, the AIMS has got more than 4,500 crores as his budget. The Jipmer and Pondicherry, PGI have got somewhere around 2,000 and 2,500, while KEM budget is about 700 crores. And I'm sure the state government budgets are much lower than that.
Yes.
And I think, if you see the comparatively, to give a simple issue, I'll tell you, library budget of AIMS is 20 crores, PGI is 7 crores, and KEM is 3 crores. And government hospital is 85 lakhs, that is JJ hospital. Now look at the difference in the kind of budgets which are there. I've gone through this and we have studied this, fought it at different platforms in a big way. What happens, budget, but as you rightly said, many times budget may be important, yes, it will not, but 100 beds and 7 staff is too less. I can understand that is not acceptable at all to me. Their secretary has to intervene and he has to do something. He cannot accept 7 staffs or 100 beds. I think that is lethal, I would call it basically.
I just recall one instance when one of the principal secretary health was called for hearing during our tenure, and he willingly signed an undertaking that he gives an undertaking that they will be all comply with that. And when one of our BOG members said, how can you sign this undertaking without checking with the chief secretary? Sir, he said, sir, today is my last day. Tomorrow I'm moving out of the.
Yes, that's the whole part of it. But I think I understand we can have, everybody must be having so many stories about how we have faced all this. But the point here is, this standard of care is going to go more and more. It is going to come. Then now people are more aware, and like West, I think our people are going to, though we say CPA is abolished, indirectly we are still in purview of the practice, and practitioners still have to face courts and all. I think there is a need for everyone to pull up their socks and try to see that how we can bring it into the curriculum, how the various associations try to do it for at least their own major diseases or major guidelines that need to come out on this. And all councils also need to see how we can at least put it, some framework, a conceptual framework has to be put in a place where people would like to work. And then we need to see how we are going to tighten it over a period of time so that ultimately a standard of care will be given. So this is a thought which is extremely important, and all of us probably need to put in our efforts to do this. I personally feel after going through so much of all this for last 5 or 7 years, I feel sometimes that we are far away from really establishing quality at all levels in our health. Our aim should be to improve quality rather than only numbers of medical colleges.
I have a doubt and question to Dr. Reena also. That do you think the National Medical Commission and state council can have their own guideline for standard of care rather than leaving it to respective association to have their own criteria?
Yes, definitely. The ethics committee of both at the state level as well as the NMCs, they can frame these guidelines for standard of care. So that can be done.
Can be there, but it's a very tedious process.
It is tedious.
It's a costly process, to call so many years. Now we can do it on Zoom, but
no, it can be done
to record all that online. And
NMCs anyway working virtually.
Yes, but we can really, everybody has to do this as a thing, and every association, I think associations have to help with NMC, and they have to come out with these kind of guidelines. At least on each association, it brings guidelines on, say, 10 common kind of diseases or issues in their thing. It will still improve like, for example, we have got now Tokyo guidelines, which you revise it 3 times over last 15 years, dynamically. Now that becomes a standard guideline all over the world. And they can be adopted in our own country, modified slightly. I think if you start doing all these things, especially, you will find that will be a much better exercise. May not be able to do for everything, but at least a few subjects or few areas, every specialty does it. I think it will be still way ahead.
The states can first start framing their.
Dr. Reena, you are saying something?
I was saying
Dr. Gupta, can I
their
take
level with their associations, with various associations can start framing at their level, and then it can, brainstorming can take place virtually, maybe for all the states with the NMC at a later stage. Once the
sure. I think that is the way, because the NMC itself may not be able to do everything. We have to take help of associations and peer groups to see we built in. And I think NABH has a big role of bringing in the process quality, I think, and ultimately outcome. So that, I think, some of their principles are very good, actually. We need to adopt.
Dr. Jamkar, you are saying something?
I think I will leave now, because now I'm getting disconnected. So I think thank you for inviting me for this wonderful discussion. I just want all of us to put together all our thoughts and put it and publish it somewhere, so that it becomes a document. Thank you for inviting.
Thank you, Dr. Jamkar.
And I'll leave now.
Thank you, Dr. Jamkar. Yes. Thank you. Yes, Dr. Kalra, you were saying something?
Most of the clinical associations are coming out now with the guidelines. The problem is that every year the top changes. Then to continue or follow up, as rightly said, these guidelines are dynamic. Then people forget actually to modify. Very few people are there. Definitely some associations are very active. They have come out with very good guidelines, practice guidelines, and they also do revise from the time to time. So I think NMC especially must be in touch regularly. They should talk with the associations to frame the guidelines.
I
Sure,
think that's a very
absolutely.
valid point. Valid point. Even during my tenure, I tried to upgrade the curriculum, which was been discussed with different specialty. I was in charge of the super specialty and some of the curriculum, and so they were so old. So we tried to do that, but
Yeah.
all our
Sir,
associations are really
Sir,
not non-regulatory. They don't have
Sir,
power.
what has happened, what we have corrected in 2012 and 16 and 18, now it's become again 5 years
Outdated.
old. It's
Yeah,
time to
outdated.
change now.
Yeah,
See, it has to be a dynamic, as I said, process
Dynamic
has to be dynamic,
Yeah,
no?
it has
Every
to
3-4
be.
years, somebody has to have a look and add a few things, cut down few things. And this has to be continuously done. I think it requires a large network of people to do all this.
Yes, yes. I mean, you rightly said every association must have a separate sort of
Particular
force
wing.
which can which can keep
Educational
on
wing.
doing, which can keep on doing this. And at the same time, it should also be a welcome step by the regulatory body to accept the recommendations of the association. It should be both way.
We see the trend nowadays, whatever few recommendations the government invites, and the selected members are, you see, most of the time from the public hospitals. They not involve by and large the private hospitals.
Sure. I agree
Or
with you.
their involvement is much less compared to the public hospitals. AIMS, like I will give the example of AIMS. Everything, AIMS is definitely there, but there are so many private hospitals, they are doing so much good work and they have expertise. They are not invited.
Sure, sir. True. See, even you quoted this PMYJ SDGs. No, I think I remember I must have created so many for the state SDGs and all. But the biggest problem of this is when you're creating it, as you said, people try to keep the focus cost related, rather than the quality related.
Yes.
And that is my concern. Especially
That is
when
the-
people created how he should not use more than this material, and the cost should be minimum, bed should be 2,000 rupees and all that. But what about the impact? I think it's very important, sir. Overall, people have to understand this quality and impact more rather than only that he has to finish within 60,000 or 50,000. I think the whole purpose of that standard guidelines was to reduce cost rather than or prevent excessive material use rather than or fee charging rather than the quality. So one needs to change that approach towards quality.
Yeah.
Okay, sir.
Sir, you're on mute.
Yeah, Dr. Reena, to give her mind of last 15 years of association with regulatory body and what she could not achieve in those 15 years and what the body
What
should
is the
be
wish
doing.
list? What is your wish list, Reena madam? Tell us.
My wish list doesn't make any difference now. It's anybody's wish list. But what I feel, sir, is that we should actually, be associated with NABH. We means the NMC now should be associated with NABH and make it mandatory for medical colleges to at least establish some kind of processes so as to improve the standard of care, which is actually not there in many of the colleges, whether it is public government colleges or private colleges. There are very few who are actually implementing proper guidelines for patient care. So that is one thing that I think that is the first step that they should take up. So that is the way, like even the medical negligence cases would reduce, because once we get processes into place, then even these cases would reduce, less of litigation, less of harassment for doctors as well as patients. So overall the quality would improve. which is what we are looking at the moment.
Yes. No, but I mean, like I remember Dr. Talwar used to say that NABH is a totally independent body and we cannot trust on the other body. Can't the parameters of NABH be implemented as part of the regulation of the regulatory body itself, which is a state council and national council?
Yes, sir, NMC can do that because that board MARB has been created for the purpose.
Yes.
So if they don't want to, they can just don't want to adopt NABH as it is. They can frame guidelines, similar kind of guidelines.
Sir, what your suggestion is?
The government standards are there similar to NABH. The government has formulated the NQAS standards. Why can't they use their own standards? If they think NABH is a third party.
Sure.
Yes.
Sir, I think what sir says that
some of
the standards of NABH, some of the standards of NAC have to be implemented and taken, like something like say clinical audit or those parameters from NABH or some of the parameters. Now, see, we have to give some time to NMC. See, NMC is hardly 2 years old, sir. I think the MAB and during Corona time, I'm sure the development has little been slower. So once I think they start developing the standards, I'm sure we can continue, definitely give a suggestion to them that you take these standards and try to put it into your newly developed or something like that. And I'm sure they must be also thinking at their level to see how this can be brought in. And if the new board, that accreditation board, if that brings these components, I'm sure then the public system, whether it's a private system, will have to adopt this, and then automatically you'll find that even the DNB courses will have to take all this, and automatically the quality will be then preference rather than only the numbers and the size and all that kind of thing of a hall and all. I think if you try to bring these clinical audits and impact into picture, it will be of a great importance to improve the standard of care.
But sir, the fastest and best method would be adopting NABH guidelines, because, and like MCI, like you said, sir, Dr. Gupta, that MCI couldn't do it because it was a third party sort of a thing. But
yes,
NMC Act allows NMC to accept third party association.
Yes.
So that would be the fastest thing and should be done actually.
I think that is what is the outcome, that we have to improve our own power of implementation. We have to improve our own criteria for doing a minimum standard. And we should try to excel on that. We should not limit ourselves only to the minimum standard. There should be incentive given to people, those who are excelling in that minimum standard. And that is
I feel, sir, instead of directly adopting NABH, I think NMC should take that components of the NABH should be made mandatory, and some components at least. Actually, that is the beginning way to go. Because if you try to say NABH, there will be a lot of criticism and reaction of the people. So I think we have to see how we are going to implement it. And we have to see, yes, it may be ultimately long run, it may be NABH or similar kind of thing is necessary. But for the time being, at least there are some good qualities of that, definitely good, some few easily accessible criteria that is have to be there. Once people get used to it, then the acceptance and people will start doing it. Because otherwise it will fail. I think when we are trying to look at these kind of things, taking out a circular is very easy. But ultimately, if it is not implemented, then, you feel very bad. This has not happened.
Implemented and then assessed for it.
Yes, exactly.
Now, that's the key question here. How do you assess? How do you keep a monitoring of that? So you need another manpower source to follow that, whether it is being done properly or not.
No, that would have to be incorporated in the assessments that NMC is doing.
So we have to select some key performance indicators.
Yes.
And we have to just see KPIs and put some KPIs and just test on those KPIs.
Yes.
I think people would initially try to focus on that, but over a period of time, it will happen.
Yes, I think, I mean, we all senior owe some responsibility for young graduates to have their safety standard maintained for them. Yeah, Shritil, are we okay with time or we exceeded the allotted time? Shritil, are you there? Normally it is
already left.
We have some time. So we have some time. Around 10-15 minutes we can go. We can talk.
Normally it is for 1 hour, so we already exceeded 1 hour 20 minutes. Yes.
I think Reena madam, you can have answered. There were 2-3 questions into the chat box, which I tried to answer, and I think you can also add to that. One of the questions was from Dr. Mangesh Tate, I think. He
Yes,
asked why corporate. So I answered that question.
Yes.
He has another question, which is Union Ministry of Health establishing one single Indian mode of medical education, awarding one single UG and PG super and sub-specialization like American and European boards. At least Indian board should be established. I think, what is your take on that, Reena Madam? You can really answer that.
One
And
single
you will-
Indian Code of Medical Education, awarding one single
Then-
UG, PG, and super. No, I don't think we, because we already have the council who's NMC now, which is looking into the qualifications, and even next is coming in now. So all that would make all the qualifications from different universities at par basically in India. So I don't think there would be a requirement for such a board if next is implemented and is successfully implemented.
Sure.
Actually,
I think that's
historically, if you go, the National Academy of Medical Sciences was brought in for this purpose of getting, because I remember when I was going there, the Indian degrees were not recognized, the British qualification, etc., British board. So they made the National Academy of Medical Sciences, where the person who is recognized and qualified, then the qualification was recognized overseas. But that has, once the National Board of Examinations comes in, NMS loses importance. But I think this is, like you said, it is very difficult to have one single board for all the type of, and what is the role which is already being played by the NMC. So I think very, very important thing. Now, my question was, Dr. Kalra said, one hospital, 7 nurses, 100 beds. There may be many instances even of in a metropolitan city also, not only in villages. I know this is happening all over. So the Clinical Establishment Act, apart from the regulatory body, what is the role of Clinical Establishment Act in such cases? How can that be utilized for maintenance of the minimum standard?
Actually, IPHS standards, I think, are being to be implemented at least by the public hospitals. If even those are implemented, things will be much better.
No, I think, I mean, this is very important. Like my personal experience, I have my own nursing home, which is registered with BMC. Every year there's an inspection. Every year I have to upload my document, my nurse document, number of things. That regulation is still there. But there are many cases where a qualified nurse is not there. There's a ANC there, and all sort of things are happening. So we have to come out with some sort of a guideline that this is the minimum thing.
Guidelines are already there, very clear, sir. There are definitely the number of nurses required mentioned in the IPHS standard is all qualified, very clearly written. But most of the private hospitals, nursing home, they are employing ANMs and other trained nurses. They tend to project them as a qualified nurses.
Qualified nurse, yes.
The problem lies in the implementation. The guidelines, IPHS is
the implementation.
PA is there, but they're all voluntary. So
there's a very famous case in Bombay where a non-medical person posed himself as a doctor, and he was working in ICU for 2 years. Later on, it was realized, I mean, it's like credentialing. How can you allow a person without verifying his degree certificates and other things? So there are so many cases which have happened in our hospital.
There are so many Ayurveda and BAMS and BHMS doctors. I had actually done an NABH assessment for a small, it was, I think, a cardiac center in Mumbai, Khar area only, I think. I forget the name now. But they had employed these BAMS and BHMS doctors to work in the ICUs, the cardiac ICUs.
Yes.
So obviously, the NABH, we had mentioned it in the report, and NABH did raise an objection, and it was not cleared. But this is what is happening actually, in spite of the guidelines.
I think that is a problem. There's another question, actually, somebody wants to take it. Do we have a regulatory body in India to ensure the safety and efficacy of anti-cancer therapy? As far as Ashok, I don't know. But anybody has any idea, you can answer that question.
I don't think, sir, there is such a regulatory body, but probably maybe the oncology associations and all, maybe may have some guidelines, but there's no
No,
regulatory
there is
body.
no regulatory body. Only, I think the guidelines are there. There are now national cancer grid, which are creating Indian guidelines. That's again, sir, very nice kind of an exercise where all the experts across India have come across, and they have been trying to create guidelines for every cancer disease.
Yes.
And they call it the National Cancer Grid. And these are available online easily, and people can follow it. Now, that is something is an attempt to create a standard of care. And these
Yes.
are again minimal. But there is no regulatory body to see whether they are implemented in each case or something like that.
Yeah.
But I think with this type of thing, if such recommendations are coming for practically all specialties and all clinical and non-clinical side, that will help in setting a minimum standard for us.
Definitely. See, the process is on, but it is slow. I
Yes.
think we need to really push it.
Yes, yes. I think with this, we'll have a closing remarks for each one. To start with Dr. Reena, what is your take-home message for people, those who are attending this?
Take-home message, sir, would be standard of care is definitely the call for the day. We have to have it in place as soon as possible. And like sir said, the process is already on, but it is very slow. So we need to really give it an impetus, a good push, so that things, at least few years down the line, we are somewhere and we do have some kind of guidelines for standard of care.
Thank you. Dr. Kalra?
Yeah, all the healthcare facilities of all levels, they must join the quality journey, maybe by joining to begin with entry level, and they should then show the continuous improvement in the quality. It has to be a voluntary, it cannot be made mandatory. Otherwise, like fire safety, so many other things will come. We need to motivate all institutions heads to undergo quality journey at least some level, minimum level, that is the entry level NABH accreditation. And then continuously after, once they have achieved that, then look for higher full accreditation. That should be by every healthcare facility, whether it's nursing home or a single person clinic or a tertiary level hospital. There's the only way we can improve some quality of the service and patient safety.
Thank you. Thank you, Dr. Supe.
I think, as everybody has said, that every hospital and individual physician or any healthcare worker should have inculcate the value of quality and safety. It should be part of it. It should be conscious about it. And unless you have that quality and safety culture inbuilt in your organization, I don't think people can really implement it or make an effort towards it. You have to realize it first, and then you start making efforts. And therefore, I think we have tried to include into the new curriculum this quality and safety issue. But now, for the people who are already in the system, need to have a tremendous awareness program and trying to make them realize the value of this. And the newer generation has to realize that this should be part of their life. I think once you make this realize, automatically you'll find that the slow change will start coming. So I think that's the way we should really work.
Actually, there was a suggestion from Dr. Pandya, Buddhadev Pandya, that we must have a national conservatory to maintain a minimum all this sort of thing. And that's what we are looking at, what each specialty, each sort of thing, how they should maintain. And I strongly believe, and what you have said, we should not leave it to regulatory body to control us. We should also try to make an effort to reach to that level of going beyond the minimum. And unless each and every one of us try that, we will not be able to. Regulatory body are overburdened with the task. So we should try to do ourselves, and that's what I always believe in that case. Yes, over to Shithil now.
You are on mute.
Thank you so much for the great takeaways of this session. This brings us to the end of the session. Thank you so much, the panelists, for your time and efforts in putting together this interesting session. To our dear viewers, thank you so much for attending this session. Do share any more questions if you have. Until we see you again, take care and happy docplexing. Thank you.
Is it available on YouTube recording?
Yes, sir. It will be available.
Can you
Yes.
share the link